All right. I think it's settling down in the joining column. So I think we can probably tuck in and get started. So thank you so much, everybody who's making the time to join today, or if you're watching this after we've recorded, welcome, welcome. We hope you enjoy the topic today. We're really excited. Today we're talking about obesity and pregnancy. Our guests today are Dr. Laura Gaudet and Dr. Zach Ferraro. We'll let them introduce themselves in a few moments, but just to warm up and get us started, I wanted to welcome everybody back to the Connected Conversations. Over the course of the series of Connected Conversations that we've had, we've been able to dig into a number of important topics related to obesity management, including discussions about all the different pillars of obesity management from the clinical practice guideline perspective. However, we've yet to really explore some of the important intersections of obesity and health. And that's a really important area to explore. And there's lots of different tangents that we're going to be able to go on. But we know that obesity is a chronic disease that impacts and is impacted by a number of other health conditions. And that's a big part of the conversations as well, that chicken and egg, what came first. We're really excited for today's discussion where we can explore the intersection of obesity and pregnancy. This is a really hot topic that we've heard a lot of comments from our community around. And we're excited to be able to join here today and have some experts in the field and start having a healthy conversation and hopefully give you guys some anchor points if you are in a moment where this is something that you're navigating. So we're going to be talking about how obesity impacts pregnancy and the outcomes for both mother and child, as well as how we should approach obesity in the context of pregnancy and all of the fun conversations that probably will go along with that. So just before we tuck in, before those of you who may not know me or have not joined a Connected Conversation, Connected Conversations is a webinar series brought to you by Obesity Canada. In these conversations, we dig into important topics for people living with obesity and connect with experts in the field. So we're excited to do that again today. From advocating to access to evidence-based care treatment, issues related to diet culture, weight bias, and discrimination, to really trying to innovate obesity care in Canada. Connected Conversations has trying to address the complexity of this chronic disease and all of the barriers that the individuals living with it face. I'm one of your hosts. My name is Lisa Schaefer. I'm a patient advocate and member of the patient community. And for the last 7 years, it has been my pleasure and privilege to serve Obesity Canada, working on public engagement and advocacy initiatives for the most part. And I am here to share my story and represent the millions of Canadians like me who live with this disease that is really highly stigmatized, misunderstood, and quite often very misrepresented. So I'm excited to lead the conversation today. And with me, as ever, is my brother in arms, Dr. Ian Patton. Ian, if you want to say hello and introduce yourself, that would be great.
Yeah, thanks for that, Lisa. Yeah, welcome everyone. Glad you've all joined us and glad you're watching this if you're watching the recording. My name is Ian Patton. I'm the Director of Advocacy and Public Engagement for Obesity Canada. I've been with the organization since I was a graduate student doing my PhD in kinesiology and then kind of transitioned into patient advocacy, sharing my lived experience and then working with a lot of other people who are wanting to become more involved in patient advocates and working with our community. So it's something I'm very, very passionate about. I really enjoy working with Lisa and doing these webinars. And I'm really excited about this particular talk today because I think it's an important one and it's something that our community has raised some questions about and it's definitely something that they're interested in. So with that, I guess we'll move on. I do have a couple quick housekeeping things. First and foremost, if you want to raise any questions, you can use either the chat feature or the Q&A feature. If you use the Q&A feature, you can upvote other ones so we don't have to duplicate questions. I will monitor both and I'll try and pull in questions where we can when relevant. If we happen to not be able to get to a question, don't worry about that. We keep track of all these things and we will follow up with them after the fact. Yeah, I guess with that, I'll throw it back to you, Lisa.
Fabulous. Yeah. So if you have anything you want to share, throw it in the chat or we'll use the Q&A feature, but hopefully this will be a very lovely, well-rounded conversation. And with that, I'm going to introduce our guests and get to the point and the heart of the matter here. So joining us today is Dr. Laura Gaudet. She is a clinician scientist in maternal fetal medicine at Kingston Health Science Center and at Queen's University. Her clinical practice focuses on maternal medicine, and she conducts cohort and clinical trial studies related mainly to maternal obesity and pregnancy outcomes. Additionally, we have Dr. Zach Ferraro, MD, PhD, is a senior resident physician of obstetrics and gynecology. Oh, I knew I was going to mess that up. Obstetrics and gynecology at the University of Toronto and holds the William S. Fenwick Research Fellowship from the Faculty of Medicine. Just a few things that you've done there, hey, sir. His research focuses on the role of physical activity, nutrition, and sleep, and how they have on preconception and pregnancy outcomes, through the developmental origins of adult disease lens. He is the incoming reproductive endocrinology and infertility fellow at the U of T and will focus his practice on lifestyle medicine. That all sounds very fancy for both of you, but I would love if you could just in human form also just say hello, introduce yourselves, and maybe tell us a little bit about the path that brought you to your work in obesity. So Laura, why don't we start with you?
Sounds good, Lisa. Hearing that introduction takes me all kinds of places because Zach and I have known each other for a really long time. I'm super proud to say that I followed his medical career the whole time, and I'm thrilled that he's going to be working in reproductive endocrinology. I think it's a huge benefit to this community. So my name's Laura Gaudet. I'm speaking to you from the stunning city of Kingston. It's warm and sunny and a beautiful fall day here today. This is the traditional lands of the Haudenosaunee and Anishinaabe, and I'm pleased to be able to present from here. My work, I'm the kind of doctor that takes care of pregnancies that are higher risk for complications. Could be for the mom or pregnant person. Here I'm going to, for simplicity, use women and mom, but of course being gender inclusive in our discussion. Either the mom or the baby has a problem, and that's why they see me. So I do prenatal clinics, I do ultrasound, I do fetal procedures, and I work on labor and delivery. Those are my main jobs. I went into maternal fetal medicine way back when because I wanted to be able to help the people that didn't have the straightforward pregnancies they'd always been dreaming of. I wish I could say that all pregnancies go off without a hitch, but I think we all know that's not the case. I became interested in the role that maternal weight has on pregnancy outcomes because I couldn't help but notice that a lot of the pregnancy complications that we follow are on the rise. And they often involve some difficult conversations about weight. So both my clinical and my research practice have moved that way. Zach, let's hear what you think.
Well, thank you very much for having me today. I've known Ian for a very, very long time back from the Obesity Network Bootcamp, and I'm really humbled to be presenting with Dr. Gaudet, who's provided mentorship and so much support throughout her fellowship and training. And I've known her since my days in Ottawa, so it's really exciting to be here today. I originally went into obstetrics and gynecology because I was fascinated through my doctoral studies on the Barker hypothesis, or the developmental origins of health and obesity lens. And I thought that if we could intervene in pregnancy, we could really help the mom, the baby, or the gestational carrier of the baby, and the future generation. Early in my training, I learned that many of the issues that happen in pregnancy, sometimes by the time they get to the obstetrician, they have already really manifested into full-blown disease. And that's why I'm eternally grateful for very intelligent, bright subspecialists like Dr. Gaudet, who are caring for these complex pregnancies. And as I learned more, I really am invested in this preconception health through the Barker hypothesis lens. And I thought, what a great opportunity to work with many individuals of different sexual orientations, help them build families, help them achieve a healthy pregnancy early on, and do that by optimizing lifestyle or medical comorbidities before the sperm and the egg have a chance to meet, to try and mitigate some of the risks, but also propagate some really helpful lifestyle behavioral changes that the data has shown and that our group has shown to be beneficial, including nutrition, physical activity, and sleep, and that's echoed in the Canadian guidelines. So thanks very much for having me today.
I love those. I love how you just said that, all of those little bits, both of you. I think that's so fantastic because you're both genuine humans that I think see a real person through all of this complexity. And I have to say, that's something that is really important to our community and something that I've heard, especially around this pregnancy and obesity conversation space, is that sometimes everything gets a little lost in the sauce and it becomes a little bit more about all of these problems and not about the person. So I love that the way you said that, propagate helpful benefits before we even leave the gate and feel hopeful about it, because I also know from experience there's not often a lot of hope around some of these conversations, but I'm sure we'll get into some of that. But let's get started at the beginning and talk a little bit about that fertility care. So Dr. Ferraro, your clinical practice leans more towards fertility care, where Dr. Gaudet, yours is more focused on care during pregnancy. I wonder if each of you could just take a minute and talk about how obesity plays a role in your practice and some of those main concerns that maybe come to play as you navigate working with your patients.
Sure, that's great. So
Whoever
full
wants to go
disclosure,
first.
I am currently still a senior resident, and I have not completed the full fellowship in reproductive endocrine, but all my spare time, clinical electives and research are focused in this area. And I've had the opportunity to work at many different academic hospitals in the GTA in Ontario with clinicians who are providing reproductive care. For me, I treat obesity as I would treat any chronic disease. And I think that that's a major step forward, that we acknowledge it as a chronic disease. I acknowledge that in that setting, for me, the couple in front of me is there to have a baby, and they want to walk out of the hospital with a healthy baby, healthy mom, and healthy partner. I'm also aware that there are issues with many individuals who I see with regards to the care they have received throughout their lifetime. The bias, the discrimination, maybe some judgment. And I'm aware of this. I don't have that lived experience, but I have spoken to many people. And I think it's important to acknowledge that when they're in front of me, even though it's the first time I'm seeing them, it's not the first time they've seen a physician, and they have not always had the smoothest journey. So I treat their concerns very seriously. I treat them as people with respect and empathy, and I try to understand what's going on. There can be many issues that are impacted in one's fertility journey, and that could relate to the gestational carrier, the mom, whether it's ovulatory issues, tubal factor, uterine issues. And it can also impact, in a hetero couple, male factor infertility, which is largely not spoken too much about, and a lot of shame and blame is put on the mother. But when we can really optimize both patients here. So I try to understand the gaps, what we can do to help optimize their chronic disease, understand their comorbidities, the medications they're taking, their medical history, and do a little bit of detective work to see how we can kind of optimize things, make appropriate referrals, whether that's to an endocrinologist, to a social worker, to a cardiologist, depending on their medical issue, to try and help them achieve a healthy pregnancy. I think it's also important to acknowledge that there is data that says there are risks, and I believe this data. There are meta-analysis, systematic reviews, clinical trials that highlight risk. But just because there's risk doesn't mean that there's no hope, and that we're here to identify these gaps to limit the ill effect of the risk to try and optimize the pregnancy. So I try to, encompass the psychosocial aspect of their journey through medicine, understand why they're in front of me in the clinical encounter, build a meaningful relationship, and move forward in that manner.
And when Zach's done with them, they come on over to me. One of the things that always strikes me is how very personal a subject our weight is. The whole idea of talking about it with someone else makes my cheek burn, my palms sweat. It's uncomfortable, I think, for everybody. I think through my clinical work and research and relationships with people like Zach, I've spent a long time trying to understand how to have conversations about weight in pregnancy in a way that builds people up and enables them to talk openly about things like their hopes and dreams, their expectations, and their fears. When I think about what the main issues are that I deal with when we're talking about obesity and pregnancy together, is that we know, as Zach alluded to, some, but not all people with obesity enter pregnancy with medical conditions related to their weight, something like diabetes or high blood pressure. And then we have other people that enter pregnancy without those complications. But you may have read about pregnancy being referred to as kind of a crystal ball period. Sometimes being pregnant can unmask some abnormalities like high blood sugars or high blood pressure in people who didn't have them going into the pregnancy. Most of the time, those are temporary. When the pregnancy is over, they go away. I was reflecting on sort of the physical things that go along with our job. Most medical equipment isn't designed for people who live with obesity. So common things like the ultrasound machines that we use don't necessarily penetrate to the depth that we need to image a fetus optimally. Things like our chairs in our waiting area, or the wheelchairs that we use, the blood pressure cuffs that go on arms. We just don't always have the equipment that we need. My job as a surgeon, sometimes I find myself struggling to find instruments that can let me do my job to the best of my abilities. But maybe most importantly, I think anytime we talk about weight and pregnancy, it can be triggering for people. I think in a way, anybody who's having a baby, especially your first baby, has a little bit of what we call imposter syndrome. Everyone worries that they aren't good enough. And I think we all feel guilty for everything, for having a cup of coffee in the morning or not being able to take our prenatal vitamin because of nausea in pregnancy. And for a lot of people, maybe for not having that elusive ideal weight going into the pregnancy. And there's other things, but those are a few of the issues that I sort of see on a daily basis in my work.
There's so much that I could touch on all of this that I will keep it moving, but I really appreciate that both of you acknowledge that bias and the history that people have when they walk into any physician and any care. And to a degree, we have some of us have care trauma in our pocket as well when we arrive, so we can be a little spicy. So I appreciate anytime I see physicians that really slow down and really try and unpickle that and really try and connect with me as a person. And I can only imagine at this intense time as well that would be such an important factor. So segueing into that, for many people, family planning and pregnancy should really be an exciting time, but it can also be, as you guys have both noted as well, really stressful and challenging. We've heard a lot from our community members that have said that they've been told to lose weight specifically for the purpose of getting pregnant. Dr. Ferraro, when it comes to fertility, how significant an impact can obesity have, and what does it play, and what are the recommendations for managing obesity for people thinking about getting pregnant? Because I appreciate what you said already, that you recognize it as that chronic disease, which should come with that extra layer of understanding that there's only so much that we truly can control with diet and exercise, and we all want to be healthy and happy humans. But it can feel really demoralizing when the answer just remains the same at that one note of just lose weight.
Yes, it's a great
no pressure.
And something that was really brought to my attention that when I started with Canadian Obesity Network back in 2006, I think it was. Now I'm dating myself. And the teachings of Arya Sharma and Sean Wharton and the work of Jimena really echoed the importance of it's way beyond eat less, move more. And for me, that is a long gone ideology, but I do still think it's quite prevalent in healthcare. And I'm sorry that people are subjected to that ignorant understanding of the complexity of energy balance. For me, the question itself is a little bit problematic because you're being told to lose weight. Whereas in my teachings and in my clinical work, we really try to focus on understanding the drivers of positive energy balance. And if it's behavioral related, for example, sleep, nutrition, in terms of energy intake or physical activity and sedentary behavior in terms of expenditure, that engaging in those behaviors independent of a change of a number on the scale can have a drastic impact on one's metabolic, physical, and social health. I understand that there is data that shows that in my world, where an anovulatory patient with obesity and potentially polycystic ovarian syndrome can improve their chance at a spontaneous pregnancy with modest weight loss. But how do they do that? They're doing it through engaging in different behaviors. It's the insulin resistance really that's driving that pathology, and using physical activity or changes in dietary index through glycemic control can change one's ovulatory function independent of the number on the scale. Further, if someone is engaging in healthy behaviors and decides that resistance training is something for them, their body distribution, their body weight distribution, which is not reflected in body mass index, can change. And that in turn can impact their chance at having a spontaneous pregnancy with simple recommendations. So I think the first point is to focusing on the behaviors and not just the weight, and that it's a very individualized approach, and things you take into account: the duration of obesity, the metabolic comorbidities that may be associated with one's excess weight, the medications they're taking. Have they tried to get pregnant previously? What has gone wrong? There are many different ways that we can intervene depending on where the gap is. And then lastly, we follow the Canadian practice guidelines for preconception, because at that point they are non-pregnant individuals, and recommend the lifestyle modifications where appropriate, making appropriate referrals to subspecialists to optimize chronic diseases, whether it's diabetes or hypertension. And of course, making the recommendations of appropriate supplementation for folic acid in the preconception period to minimize any risk of neural tube defects. And those would be recommendations I would give to anybody planning a pregnancy. So I treat the individual in front of me as any other individual. I just acknowledge that they have a chronic disease, and let's try to see if this is actually impacting their ability to have a baby. And depending on how those conversations go really dictates how we would unfold the clinical counseling moving forward.
That's really interesting. So we often, or I feel like I've heard in the community as well, and I personally have felt sometimes I have to choose between my obesity care and this other thing that I'm trying to achieve. Is that similar in this space? And I guess really what I'm trying to say, for if I'm at that moment where I'm seeking out specialized fertility care, how big of a role does my obesity management play in that overall fertility care? Am I choosing? Am I timing? Is it more complex than that?
I guess it depends on where you are in your obesity care and the stability and how you're managing the chronic disease the minute you're speaking to me. If the chronic disease is not well controlled, for example, high blood pressure, or most commonly we would see things with insulin resistance or abnormal blood sugars, thyroid is another example, that if it's not stable, then we need to address that. And whether or not that's related to one's infertility would remain to be seen, but we would try to optimize that. So I'd need to understand where you are in your journey, and are you satisfied with the weight maintenance you're having with respect to your obesity care? Are you satisfied? Are you happy? Are you able to sustain the changes that you're making with respect to weight management? Or are they causing you stress and adversity? Because we know that stress and cortisol spikes can alter gonadotropins and secretions and how one ovulates. And that's for the female. The male is another side that I always mention is often neglected, and I'm thankful for the opportunity to provide care again to men in this setting, because we've seen in clinical practice minor changes in lifestyle in ones who have male factor infertility can really optimize their chance at a healthy conception, and it has actually nothing to do with the gestational carrier of the mother. Male factor infertility is the second number one cause of infertility, and I don't think that should be overlooked. So the obesity care and fertility care, they're intimately related, but understanding where they are in their chronic disease management, if it's stable, they're happy, and they're ready to have a pregnancy, well, then we can almost say, without doing the appropriate investigations, that it may not be that big of a role, and that their chances of having a baby would be no different than anyone else with obesity, or without obesity, sorry. But acknowledging that there are certain risks that we may get into later today.
That's fantastic. I appreciate that, because that means you're looking at me as a whole person as well. And I like to talk about in my in my work life, in real life, I'm in marketing. And even with that, I talk about let's do what we can to control our controllables, and then we can figure out the rest. And I feel like that's a lot of the sentiment that you just expressed there as well. And I also appreciate that you talked about like, are you satisfied and can you maintain where you're at? Because that's a really big part of this. Sometimes, and I know when I started out on my journey, probably what I defined as success would look different than what I define success at now. And when I think of Dr. Sharma as well, and that TED talk that he did with the band, and if you're holding it like this, can you really hold a baby at the same time too, right? Like all of those kinds of moments. So I love that approach that makes it feel like, let's just figure out how this is going to be sustainable and healthy and a productive conversation as well. So we've talked a lot about the Canadian Obesity Clinical Practice Guidelines in our series of conversations that we've had so far, and the evidence-based pillars of obesity management. When someone is seeing you for fertility care, do the same treatment and management recommendations apply, or are there differences that need to be considered as well? So can we stay true to those obesity guidelines?
Yeah, I do like to stay true to the evidence, and I value those guidelines and the work that went into them. We do stay true to them, and I also believe that we have to be thoughtful that you're planning a pregnancy and that you'll likely get pregnant. So there's an additional layer that needs to be considered on top of the Canadian clinical practice guidelines. The main pillars, and if you look in the guidelines, for weight management over the reproductive years, they largely focus on nutritional intake, optimizing diet, engaging in physical activity if you're able to, understanding the role that medications play, weight stability, and things of that nature. But with respect to medications and bariatric surgery, which the audience here I'm sure is well versed, is the most successful in ameliorating some of the metabolic adversities of obesity. These conversations need to be had because this is important when planning a pregnancy. And I'm sure Dr. Gaudet will get into a little bit as well. We've chatted a little bit about this in terms of when to stop your medications, and when to attempt a pregnancy after a weight loss surgery. So in a preconception consult, for us, it's largely dependent on age, unfortunately. And there are some things that are just outside of our control, independent of your BMI. It's largely dependent on egg quality, which there are no true markers when having a pregnancy. There's markers for egg quantity, or the number of eggs, or the number of, they call them markers of ovarian reserve. There's a biochemical marker, there's ultrasound markers, and some experimental markers. But this is used for us to help appropriately dose medications if you go that route. It's by no means a blueprint that tells you you will or will not have a baby, and I think that's an important distinction. And these are messages that I give to people struggling with weight and without any weight-related issues. I think it's a time for patient education. How the message is delivered to those two different groups of people is different. The time it might take to have a thoughtful conversation may be different, but the messaging is the same. So, and really, in summary, we do follow the guidelines. We consider something else, in fact, that they're planning a pregnancy and we want them to achieve that. And then based on their medications, if they're taking weight loss medications, if time is not of the essence and it's a younger individual and they're saying, oh, I would like to get pregnant in 3 years, I just got married, well, then maybe they can see a weight loss specialist who is certified and endorsed by Obesity Canada, one that provides empathetic, non-judgmental care, and they may explore weight loss medications. And then when the time's right, they may come see us. However, if they're a little bit older and we know that weight loss is challenging, we know that engaging in changing behaviors is tricky, but if you're 38, 39, 40 years old, and some of the markers of ovarian reserve may be lower, maybe we move right to fertility treatment because time is of the essence and we want to try to give you the best chance at a healthy pregnancy. So it's really patient specific, but we do ground it in the clinical practice guidelines with extra attention paid to your future plan.
Appreciate that greatly. Individualized care is such a big cumbersome conversation unto itself. But I think anytime that we meet physicians like yourselves that really do take the time to understand each person and try and do some of that, as you referred to it, detective work before as well, to give everybody the best chance, I think that's fantastic. So just one last one for you, Dr. Ferraro. We know that, as you've already alluded to, this is a sensitive topic for people as well. Layering in the age is a whole other thing. Geriatric pregnancy is the worst nomenclature ever. I'm just going to put that out there. But anyway, back to this. So this is a very sensitive and emotional topic for people. And you seem like a very genuine human. And I'm sure not all of us would be fortunate enough to land in your office. So maybe even just for the lens of some of the other healthcare professionals that will see this webinar or that are joining us here today, how do you as a clinician try to approach those difficult topics in a way that is both respectful and also productive, and not just that, like, pat me on the top of my head and tell me it's going to be okay, but let's make a plan kind of action. So how do you approach that?
A great question. So first, I acknowledge where I am in my training and the time it takes me to have a thoughtful conversation, and really get down to the bottom of the issues that the couple or the patient has in front of me. I find sometimes in my training that clinicians are forced to act very quickly. There's systemic issues that preclude a long, comprehensive, well thought out meeting. So for me, when I have that ability as a trainee, I try to ask if I can be scheduled with a little bit more time. So I start there by acknowledging where I'm at in terms of my comfort diving into a comprehensive clinical encounter. And I feel more comfortable giving a little bit more time. And that's not always possible as a trainee, but it will absolutely be possible when I'm a staff physician. And I think giving individuals more time will allow a less pressured conversation, and hopefully that interaction can be perceived as less stressful, more open, and, as you just said, genuine and empathetic. And my goal is to just raise personal awareness to the data that excess weight may pose to an individual seeking fertility care, but not make that the focal point of the conversation, to understand their journey, their readiness for change, and identify, and with respect to endocrine or gynecological factors that may be precluding conception, taking them through the appropriate workup and explaining the test results using appropriate posters or e-tools to help patients understand the physiology that's happening with respect to reproduction. Engaging both partners, giving them both time to ask questions, really being an active listener, because you may miss a small part of a clinical encounter or something small that was said under the breath, or some nonverbal cues shared amongst partners that are really important to pick up. And if you unpack those, they may expose a psychosocial issue that may warrant referral to a social worker or a psychotherapist. And so just understanding the struggles, validating concerns, hearing where they're at in their journey will allow me to identify the gaps, refer as appropriate, and then make my recommendations. But I think it all starts with acknowledging that although I have training, there are other opinions. There are other experts who have different opinions, but listening to them and trying to have a fruitful conversation to give the person or couple in front of me the time they need to share their story, and then in turn give them recommendations based on that story.
I love that. I love that personal awareness towards the data is really empowering when done correctly. So I love that is part of your approach, because one of the things that I love to say is people are entitled to their own opinions, but not their own facts. So it can be very helpful to kind of separate those two as much as possible, even though the world is a lot of shades of gray right now. But so thank you for that. I think that's awesome. All right, Dr. Gaudet, it's your turn in the hot seat, my friend. So let's talk about your part of this equation. And I'd like to shift to ask you a few questions about once someone has become pregnant. For someone who is pregnant, does their weight status or their obesity status pre-pregnancy impact the outcomes of, and as you said, we'll use mom and baby today for simplicity's sake?
I mean, I think It's probably not going to be a surprise to anybody on this webinar that there are some problems in pregnancy that occur more commonly in people who live with obesity. There have been so many, and actually, in my opinion, too many studies that show this correlation that occurs. Just to list some of the examples you'll read about: miscarriages more common, gestational diabetes, high blood pressure in pregnancy or preeclampsia, the need for cesarean section birth, for example. And from the baby's perspective, they're more likely to be large for their gestational age, but curiously also at risk of being smaller than they should be. And while those babies that are too big or too small are at the most risk, there is an increase, although it's relatively slight, there's an increase in the risk of stillbirth, which is what we call it when the baby dies before being born. And that breaks my heart that that's the case. But as Zach said, there's consistent reports in the literature. So I do think those statements are correct. But the thing about complications is that they certainly don't always occur. Not every person who lives with obesity will have those complications. A couple of nice papers out there that show that approximately half of people who live with obesity will move through their pregnancy, deliver their baby, and never have any of the things we've just kind of listed. Especially in the first pregnancy, though, it's really tricky to know who is going to develop those things. And so for that reason, there is a need to follow those pregnancies more closely. And it just starts with awareness. We need patients and their partners and their care providers to all be active participants in the monitoring for complications or signs of pregnancy problems that can occur. And then when we're talking about treatment options, having everybody participate equally is really important. Weight gain is something that's, that's for you, Lisa.
Oh, sure. We can go. I was about to say, I think this would segue nicely into the weight gain conversation. So we know we've heard from the community, and I'm sure this is a hot topic for you as well, that weight gain during pregnancy is something that's can be really tracked closely. And many in our community have talked about how they've been shamed for gaining too much weight during pregnancy. It can often be that moment as well where we have some a team of caregivers, and maybe over here where I'm working with you, I feel safe and good, but I have to do some appointments over here, and then I get a completely different experience, and that can break my heart and set me backwards. So can you talk a little bit about why tracking weight is important clinically during pregnancy, and how you work with patient who is gaining weight and maybe gaining more than expected during pregnancy, and just kind of paint a picture for us of what that looks like from your perspective?
Yeah, I sure can. I mean, Lisa, I still hate that people experience body shaming in medical settings. It's kind of appalling that it does still occur. I've witnessed it myself. I know it does. I see it happening.
Yep.
That kind of concept of microaggressions. You hear the unkind words or the looks between staff people, maybe the remarks about how somebody's moving on or off the table. It isn't okay. It isn't okay. When we look back historically, we started to routinely measure maternal weight back just kind of around the time of the Second World War. And it started in London in the UK, and it was a screening test for maternal nutrition. So at a time where undernourishment was much more of a problem than it is right now. And then we just kind of adopted it, and we've all kept doing it. And certainly the usefulness of measuring weight has been questioned, but there's some belief that maternal weight gain, and weight loss are associated with pregnancy outcomes, including the birth weight of the baby and things like the development of preeclampsia. So when I think about patients that I've weighed serially through their pregnancy, I have seen people have a sudden jump in their weight. They'll be 10 pounds more than they were a week or 2 weeks ago. And in some cases, the next thing that happens is that they develop pretty severe preeclampsia. So sometimes I think that change in weight can give us a heads up that we're about to see a pregnancy complication occur. That being said, I'm certainly aware that for some people, the process of weighing them has a serious negative effect. And so given that there's not a lot of solid data in this field, if a patient indicates to me that they prefer not to be weighed, I'm comfortable foregoing that measurement. Like everything else in medicine, risks and benefits of a test have to be considered, and the test should really only be done with informed consent. So if someone's objecting to it, there's no problem in not doing it. I might explain what information I'm missing by not doing that, but we don't have to weigh people.
What information I might be missing, because that can often help mitigate that fear and that risk, or maybe we can reduce the frequency, because that is a really big one for people. And again, I think you made an excellent reference before as well, that sometimes we're just not set up for people living with obesity as well, and that can add to it. So if the expectation is also, I know at my personal GP's office, the scale is right where everybody walks in the door. It's just right there for everybody to hear that good clangy noise, all of those things, right? Like, but that can have an impact. And if we can reduce some of that noise and that internal chatter for people as well, it's interesting to see. But I also am really fascinated that the data about what we do with this information, I did not know about that before. That's really interesting. So should someone who lives with obesity focus on actively trying to manage obesity once they do become pregnant? And if so, what approaches to obesity management would you consider starting someone who is pregnant? And we know there's so much conversation in the media right now around medications. So that awareness of medication is growing as well. So I'm sure that maybe conversations in your meeting rooms have also been changing a little bit of late. So I'd love to know your lens on that as well. And like, how much do I jump into that conversation while pregnant?
When I was reading this question, I thought, gosh, that's kind of a tricky one to answer, because I think the answer depends on what component of managing obesity we're talking about. I know Max said the same thing I'm about to say, which is that I usually start with encouraging positive lifestyle choices, getting good sleep, eating a healthy, balanced diet, getting regular physical activity. And I know how challenging this is, but trying to reduce your stress. This is not a time where you want to be moving with heightened awareness of everything. I ask my patients, for the most part, to try to maintain their current status rather than continuing to actively try to lose weight. I do have some of my patients that work with nutritionists or dietitians. Some participate in physiotherapy. Some are working with psychologists. This is the time to build a positive team around the person who is pregnant to help them, support them in making those positive lifestyle changes that they've probably already been working towards. As far as what happens to weight in general, I want most of my patients who live with obesity maintaining a stable weight for the first half of the pregnancy. You don't need to see a tremendous increase in weight in the first 20 weeks to have a positive pregnancy outcome. And then in the last half of pregnancy, we see more variation. So I try to keep people gaining somewhere between 0 and 15 pounds as a rough estimate, keeping in mind that there's a lot going on in the body at that point. So the blood volume is expanding, the uterus and the breasts are growing. There's a whole other human and a placenta and their amniotic fluid in there. So the weight change that we're seeing is no longer what people are used to hearing and worrying about. Some weight in pregnancy is probably very important. There are some studies that show losing weight in pregnancy can have some harmful effects for the baby. So if people are in that situation where they're losing weight in pregnancy, they need to be monitored extremely closely.
I love that. And educating them about those different things. I see a comment in the chat as well about edema, and like helping people understand that where those swings and roundabouts might be coming from. And if they've never had that fluid before in their feet and all of those things, you're like, what is happening to me? It's a magical experience, isn't it?
So great.
I love it. It is. It really is. It's that, like, as we were saying before, human bodies are amazing. So to that end, we know, as we were just saying, the conversations around medication and understanding of obesity as a disease and treating it well is getting a little bit better. Yay, go Canada. So I'm sure you may have encountered some people along the way who have been managing their obesity quite successful prior to becoming pregnant as well. And some of us can be quite edified and quite knowledgeable when we walk in the room, which I'm sure is interesting as well. So for someone who has successfully been managing their obesity, how would you talk to them about continuing or pausing or stopping medication? What does that turn into? What does that conversation look like? And I think that's something that I know our community is really interested in understanding as well. And do I go back to that medication? All of those kinds of moments. So let's go there first.
I share your questions and your interest. What it comes down to is that at this moment in time, we still don't have enough solid data to support the safety of continuing obesity medications during pregnancy. There is some data coming mostly from animal models that says there's probably higher risks of miscarriage and possibly birth defects in offspring. And so that's just always worrisome to us as physicians, and I think as humans in general. The human model is not that different from the animal models, so the concern, I think, is justified. So I suppose it's in the spirit of first do no harm that we recommend stopping these medications. Ideally a few weeks before conception, but certainly as soon as possible in pregnancy. And so this is where Zach and I sometimes overlap. When people are facing a longer journey to become pregnant, the idea of stopping the medication can become really stressful and potentially lead to some problems. When we do stop the medication, there can be some problems, and I'm sure people are aware of that. I'll just use one example. Right now, the medication I see the most is Ozempic or semaglutide. That's the one that I see the most people coming in on. The way it works, it can be used for obesity management, but it can also be used for people with diabetes. And so one of the biggest problems with stopping it is that then all of a sudden the blood sugars may no longer be normal. And we know that having high blood sugars can cause birth defects in babies. That correlation is well established. It's only one of the problems that we see. Weight regain is a real thing, and it happens very quickly when you stop the medication. I've also had patients report some side effects, things like mostly GI, vomiting or diarrhea, just that general discomfort upon stopping it. So I suppose to sum it up, at this point, we're recommending that people try to wait about 2 to 3 months after they stop their medication before they try for pregnancy. And I would prefer that they do that in consultation with their doctor, who can help make sure that the blood sugars stay well controlled. And then at that point, that's also the time to talk about behavioral habits, appetite, mental health, both before and after pregnancy.
So if someone comes to you and they're still on their medication and they're pregnant, have you had to have that intervention moment? Just
Yes,
this is me being a nosy Rosie more than anything.
I have had it happen. The strategy is just to stop it as soon as possible. Biologically, if the medication is stopped by the time the period is missed or within the first few days afterwards, there should be no effects on the pregnancy if it continues. Some people may still miscarry, but it's early enough that birth defects are not a problem. It's a bit of a bigger deal if people have still been on it until a bit later, 7 or 8 weeks of pregnancy. Then we do have to have that conversation about possible effects on formation of the embryo.
It's all just about a conversation and educating each other. And I think this is an interesting moment for me. I want to talk to my patient community and just talk about that building trust with the team of people that you're going to be working with as well. We can sometimes hold our cards close to our chest or not want to reveal everything, and that can end up causing more of a ripple than it's worth as well. So the more we can do to create these healthy dynamics with the physicians and the people working with us in these moments, I think the better off we'll all be. So that was just me on my soapbox for a moment. But to that end, and with a lens on my patient friends, for both of you, what is one thing that you would like patients to know before they come and see you clinically? Dr. Ferraro, why don't we go to you first?
Yeah, it's really for me about the messaging, and I want them to know that the clinical encounter is not easy for me as well. Want to provide them with the best care in a non-judgmental way. And I acknowledge that they've likely had tremendous hurdles and inappropriate comments and care throughout their lifetime. So I'm trying to temper my expectation and be as open and transparent with them that I'm there to help them. And that someone, when they're in front of me, even if it's the fourth or fifth patient I've seen that day, I know that that's the first time they're seeing me. So I need to take a breath and check myself to make sure that I'm giving them their full attention, that I acknowledge that their history, and that I'm trying to practice in my best ability the messaging of Obesity Canada, to just give a non-judgmental, non-biased care to understand their story, and in turn give them recommendations that we can have a conversation about using the 5A's model when appropriate. And then it's not an easy conversation. It's going to require time and honesty and transparency, and that we can go over the data. We can be fixated on numbers, or we can try to understand the take-home message of the data in the context of the patient's story who's in front of me. And I think that that's the most important. So just I want them to know that I'm there to help them, that this is a clean slate, that I might not have all the answers, but I will do what I can in my power to make the appropriate referrals when necessary, to try and give them the best chance at having a healthy pregnancy. We see many people who have come to certain clinics on their third or fourth consultation. And when I'm reviewing some of the notes and some of the impressions in the plans, I can see that maybe the patient has not been fully listened to, or there's a disconnect in what was said and what was recorded. And so I'm here to try and to reconcile that, and just to provide a recommendation. It's by no means law, and that we can learn and work together to try and give them the best outcome possible, acknowledging that there are certain risks and there will be difficult conversations had.
I appreciate that. As someone who has to navigate difficult conversations in other spheres of life, I like to call a thing. And I often will start by saying, this might not always be the easiest conversations, and we're both going to feel a little bit knees and elbows, but we have the right intent and we both want to work together. So let's focus on getting it right and those kinds of moments. So I enjoy that human approach. Dr. Gaudet, what about you? What would you like patients to know before they?
I think it's almost comical how Zach and I are cut from exactly the same cloth. He's used a lot of the words I was thinking as well. I think what I'd like people to know is that I'm not perfect. None of us are. I try to do my very best to support my patients' physical and mental health. And I spent a lot of time thinking about how I would want to be treated or talked to, or if it was my sister or a close friend of mine, how would I want their experience to be? I'm always focusing on trying to meet people where they're at in their weight journey, because it is a journey. You're not starting with me. But I need to give you information that is important to making sure that you have a healthy pregnancy and a healthy baby at the end of the day. I suppose if I could implore people one thing, just please speak up. If you think I'm talking too much about weight or not enough about weight, you're an active participant in this process. And so it is, as Zach said, only through open and truly honest conversations that we can do better.
Love it. So to that end, Ian, do we have any questions that we want to bring forward from the community at this point?
We do. We have a couple that popped up. This one, I think, so we've ended up talking a lot about weight stigma and how you, as health providers, have seen this actually in clinical settings. I think both of you have expressed here that, you're kind of, I don't want to say abnormal, but you're you're more advanced in your knowledge about obesity, and so you have a more comfortable, I guess, conversation, or you're able to manage those interactions with your patients. You're more aware of the weight bias and stigma that people are experiencing. So this one person was asking if you felt comfortable calling out these behaviors when you see them from your colleagues, which I guess is a really interesting question. But I guess, and something I can maybe speak to a little bit afterwards, is how do we develop more care providers like yourself who can acknowledge that stigma and have that more individualized healthcare that you guys have described.
Yeah, I mean, speaking of awkward conversations, try calling somebody out on it. It's interesting because the way our clinics work, I see my own patients. So I don't tend to see on a day-to-day basis other people interacting with their patients or my patients for that matter when they need to. I do call people out on it, yes. That may be the most delicate conversation of all. But it never hurts to say, have you considered how that sounds or how that might make someone feel when you say that? From a practical perspective, we sometimes do have to have conversations about someone's body size and what equipment do we need to have. And so we always try to be very respectful in having those conversations, but sometimes they still do need to occur, usually behind the scenes, but sometimes in the presence of the patient as well.
Yeah, I think I guess from our side of things, as patients and within our community, a lot of times, because of the history of the weight bias and stigma and stuff that we've faced, oftentimes we can almost vilify health professionals. And I think that's kind of the wrong way to go about it. We do have a lot of excellent health providers who have, understand obesity and have those respectful conversations and are able to manage it in a appropriate way. I think I don't think there's a lot of doctors and health professionals that get into the work that they do with the intent of being mean and doing these things to people and intentionally harming people with the way that they speak. I think a lot of it has to do with education, and obesity, unfortunately, is something that is not well taught, I guess, across the board in all these different professional settings yet. And so, it's an evolving area, and it's something that there needs to be more professional development and education. And so one of the things Obesity Canada does is we work really hard in that area of education around obesity management, evidence-based treatment, weight bias, and all those sorts of things. So you can look to our website and the professional education if you are a health provider to come and check that out, like our Caliber program, which is based on the clinical practice guidelines. And I think really just being open and able to have those vulnerable conversations between the patient and the providers is a really important first step.
I think this topic is one that really lends itself well to our approach on trying to get information out for all obesity patients or people who love someone who has obesity as well. And that is that we're trying to get to the physicians and the healthcare providers top down with our clinical practice guidelines approach. And then we look to have conversations like this, and Ian and I go out and we try and bang our drum so that we can make sure that patients understand that they can walk into your clinics and your areas informed and educated and asking for ground rules for how we're going to engage each other as well. And I'm hopeful that that's going to help as well, because you're right. It is tricky to call out your peers, I am sure. But, the more we can do to help patients walk in and not have their guard up, but have thoughtful data and information to point to. And you're allowed to ask questions of your physicians as well and find out how do they view obesity? What is their lens on this and that? So you can decide who is going to be on your care team, especially in a moment around pregnancy, where again, we want to bring back the hope and we want to bring back the positivity around let's figure out the best possible outcome of this moment, while also recognizing that as delightful as you both are, you are not magicians and you don't have magic wands and crystal balls to say how things are going to go, but we can provide a safe place for conversation and connection. So I thank you both for joining us here today for this connection and this conversation, and I hope it will help others have more out there in the world as well. If we haven't touched on something that you are interested in, please feel free to join us over in our Connect communities. We have a pro community for healthcare practitioners, as well as the or OC Connect, pardon me, is our patient community, where we really do try and get as much insight from the community as well and find out what it is that you guys want to hear about and get more information and empowerment around, which really led to this fantastic collaboration and having this focus on obesity and pregnancy. So thank you again, both Dr. Gaudet and Dr. Ferraro, for joining us today. Hopefully everyone can take something from this. And then, as Ian was mentioning, we're going to continue the conversation. He mentioned it in the chat. In November, we're going to continue the pregnancy and obesity conversation with a little bit more conversation around that stigma and bias, and really helping people navigate those waters. So again, feel free to reach out for any resources, questions, concerns. We are here to help. We want to make Canada as happy and healthy as we possibly can. And I hope everybody enjoys the rest of today, whatever that looks like for you. Please be kind to yourself and at least one other person. Wash your hands and take good care, everybody. Thanks for this hour. It's been fantastic.
Thanks, everyone.